I'm Jenny Burke, a Senior Analyst from Wolters Kluwer, and joining me is Lee McMillan, our Senior Product Marketing Manager. Before we begin today's webinar and introduce our featured speakers, I just want to cover a few quick housekeeping items. Please use the Q&A menu bar located on the GoToWebinar menu on the right side of your screen to submit questions, as all lines have been placed on mute. To download a copy of today's presentation, select Handouts tab on the GoToWebinar toolbar and follow the instructions, or use the URL that was sent out in the reminder email this morning. Today's webinar has been approved for 1.5 hours from the HCCA. An email with survey and download instructions will be sent within 1 to 2 business days of the webinar. And now I'd like to introduce Robert Roth, a partner at Hooper Lundy Bookman, John Hello, a partner at Hooper Lundy and Bookman, Martin Corey, Chair of the Government Relations and Public Policy at Hooper Lundy and Bookman, and Hope Levy-Beal, also a partner at Hooper Lundy and Bookman. And I'd like to now turn it over to Bob Roth, if you would like to begin. Thank you.
Thanks, Jenny, and hello, everybody, and thank you. Thank you so much for joining us today as we talk about these three important developments. The final IPPS, the IPPS final rule, which went into effect on October 1, 2015, the Outpatient PPS final rule, which goes into effect on January 1, 2016, and the Bipartisan Budget Act of 2015 that was enacted on November 2nd, 2015. I am pleased today to be joined by Marty Corey, the chair of our Government Relations and Public Policy Group, and also by Hope Levy-Beal and John Hello, who are co-chairs of our regulatory department here at Hooper Lundy and Bookman. What we want to do today is this is a kind of an issue spotting webinar. Each of these topics could easily be their own webinar. But what we want to do is present it all, make good use of an hour and a half of your time to give you a high-level survey as to what was included in these final rules and what you need to know about this new law that went into effect on November 2nd. And so for the most part, we're going to be going through these things at a high level, but there will be time at the end for questions to get into detail. And of course, you could always contact us offline if you have any questions to follow up on the things that we've discussed today. At this point, what I would like to do is hand it over to John to provide a little bit of an overview of Medicare spending generally to set the framework that we're going to be using to talk about the inpatient PPS final rule. John?
Thanks, Bob. So I love this particular slide, and I've used iterations of it for probably about 7 or 8 years now. The unfortunate thing is that the economic report of the president for 2015 didn't provide any updates of this information, so we're still stuck with 2014 information. But what this suggests is these are CBO projections of Medicare and Medicaid outlays as a percentage of GDP. What these suggest is that ACA is kind of working, that it is doing a pretty good job of reducing the increase in the spend for Medicare and Medicaid so far, and that trend, is viable through data of February 2014. There have been suggestions that cost of program is escalating significantly, but the data indicates that while costs are still going up, as a percentage of GDP, healthcare is flattening out pretty considerably when you look at the May 2013 and the February 2014 trends as compared to the August trends from 10, 11, and 12. Bob, next slide. This is a sort of a brand new piece of information from CBO, became available in June of 2015, and this is actual net Medicare spending, so not as a percentage of GDP, but the total dollars projected to be spent by the Medicare program over the course of the budget window, basically through 2024. And what you see beginning, around 2019 is that net outlays start going up fairly significantly. And there are some pretty easy explanations for this. A number of the significant ACA savings actually begin to phase out after 2019. And the CBO estimates take this into account. Now, so why is this important? Well, this is important because it shows a trend of a ramp up in Medicare outlays that I suspect Congress is not going to allow. And Bob will talk about some of the ACA adjustments that are made to the market basket increase for IPPS purposes. But in the last 3 years of ACA, so through 2019, one example is the 0.75% reduction to the market basket increase for IPPS payments that literally disappears beginning in 2020. Now, given this trend of increasing outlays, does anyone think that Congress is going to let us keep that increase? Likely not. It's probably, going to be factored into some future budget savings, and I would imagine we'll start seeing some of that potentially this year. Certainly hope that doesn't happen, but with the trend in outlays, starting to escalate beginning in 2020, and a budget window that now extends out through 2025, 2026, I'd expect that Congress is going to look to capture some of this increase through a continuation of some of the ACA cuts, unless ACA is completely eliminated. And I don't think anyone's actually talking about eliminating the cuts to hospital payments as part of any repeal of ACA. So I think two, sort of important trends to keep in mind. ACA is generally working, but aspects of ACA do get phased out, and I think it's likely that we'll see them sort of extended to continue those savings. And Bob, it's back to you.
Well, thanks, John. And just for those in the audience, who don't typically look at these kinds of charts, I think John is right to call your attention to them, because what they do, at least from here where I sit in drizzly Washington today, is they affect the debate in Congress. And so the takeaway is, oh, look at how much these costs are going to go up. And really the takeaway is going to be, wow, Congress is going to do something about it. And one of the areas where Congress has been doing something about it with respect to Medicare for several years now has been with respect to the market basket. There is an annual increase, what they call a market basket increase, that affects inpatient PPS. Some people think of it as an inflation adjustment, but the amount that the IPPS payments will go up every year, the total number of payments that's used for budgeting purposes, and that's called a market basket. And the market basket takes into account what the growth is expected in costs to the program. And so as this slide says at number 2, CMS every 4 years looks at, rebases this market basket to see if it's including all of the right factors, and then uses that factor, that basket of factors, to determine how much they should use for budgeting purposes to expect Medicare costs to go up because of inflation and things of that nature. And so in 2015, the IPPS final rule included an update of 2.9%, and in 16, a little lower at 2.4% in the final rule after proposing 2.7%. So when folks, if they focus only on the market basket, they may think, wow, 2.4%, that's not really that bad in light of what, lower inflation and things that been experiencing. That's a kind of an okay increase. But that's actually misleading, because in order to really understand what happens with that market basket, you need to understand what Congress and the administration do with that market basket. One of the things they do is they adjust the market basket through legislation. And as John indicated, when ACA came in, there was a deal. And the deal was that hospitals were going to contribute a significant amount of money to ACA in exchange for the idea that there would be broader coverage, broader insurance coverage that would lead to fewer uninsureds and presumably more money that would flow to the hospitals, so that they would agree to accept less from the Medicare program in exchange for what they should be getting paid through these changes to the exchanges. And this is a mandatory adjustment, and up through this current year, 2016, that we're in, the federal fiscal year runs from 10/1 to 9/30. So for federal fiscal year 2016, the market basket adjustment is a 0.2% cut. But what John was alluding to, in 17, 18, and 19, that goes up to 0.75%. So that's a significant increase in a reduction in new money, additional money that would be made available. Now, I think that if you look at this, 2019 is the final year for that cut. And but there are some, and I think John's one of them, who wonders whether, in fact, Congress will allow those cuts to lapse after 2019, or whether you will see some kind of form of market basket adjustment that gets enacted that will be used to reduce Medicare expenditures going forward. I don't know, John, if you want to comment on that. But
well, there's certainly precedent for this now, Bob, and we'll talk about it a little bit. There was legislation last year that recaptured what should have been a fairly significant increase in fiscal 2016, beginning in fiscal 2016, for documentation and coding, which I think you're going to talk about yet. So there's certainly precedent for the notion that Congress, when it sees that hospitals are going to get a fairly significant increase in IPPS updates, they claw that back. Unfortunately, but the trend, got evidence of it now, and I'll leave that for the moment.
Yeah, that's right. And so what we've done now is the 2.4 has gone down to 2.2. Well, it's gone down even farther because now there is also a productivity adjustment, and this is the productivity adjustment is an effort to measure the changes in efficiency, usually more efficiency, in the delivery of services. And so the idea is that because healthcare providers are generally becoming more efficient because of technology and other issues, that the general cost of delivering services has gone down, and therefore that needs to be taken into account. And the idea is that that should be used to reduce this inflation factor or this market basket. But one of the problems here is that there is not a factor that is limited to healthcare services. And so what's been used over the years is this 10-year moving average of changes in non-farm productivity, and that these can actually result in negative adjustments, or adjustments that are so big that the market basket increase could go to lower than zero. That didn't happen this year. As this slide says, 0.5, 0.5% was proposed, and 0.5% ended up finding its way into the final rule. So the effect now is that we started with the market basket of 2.4. We reduced it for 0.2 for the ACA cut. We're then reducing it by another 0.5% for the productivity adjustment, which brings us down to 1.7%. John was alluding to, yeah.
If I could just interject briefly, I just wanted to give folks a heads up. So some academics and BLS have actually been working on a hospital productivity measure, and at least beginning this year, there will internally be a measure of hospital productivity. Whether they're going to roll it into this adjustment and replace the BLS non-farm productivity with the hospital productivity measure is questionable, right? I think it's unlikely that they'll revisit that, but there will be some data starting this year on hospital productivity.
Right. Good to know. Good to know. Thanks for that update, John. Another cut to the market basket has to do with documentation and coding adjustments. And this arose when there was the increase in the number of DRGs, and CMS made an assumption that there would be a tendency of providers, now that they had more DRGs, to code higher, even though there would not be a change in the severity of the patients that they faced. And so the behavioral change that was taken into account was made for several years to adjust for payment increases that supposedly were to occur in 2008 and 2009. And those were phased in and completed through 2013 and resulted in a total recoupment, as you see at the bottom there, of 5.8 percentage points. That's historical. Then what happened is in 2012, the Congress decided that there needed to be another $11 billion recoupment because of these coding behavioral changes that led to what Congress believed to be overpayments for 2010 through 2012, and those amount to 0.8% per year. Secretary has a right to fiddle with that, but didn't do that. So we had another 0.8% per year that went to these document and coding changes. So now, in addition to that, and really kind of this slide is a little bit of a detour because it doesn't apply to all hospitals. Everything we talked to before applied to all hospitals, and what we talk about next will apply to all hospitals. But there are other hospitals that will have their market basket rate of increase affected depending on their ability to implement the EHR and quality data reporting. And this slide simply shows what could happen to hospitals that don't comply. If they comply with both, they won't have any cut at all. If they don't comply, there could be cuts of 1.2%, 0.6, or a total of 1.8%. And if a hospital didn't comply with both of those, they're already negative, and we still have other things to account for here. Now, one of the more controversial issues that we've all been hearing about, and some of us dealing with this, and our firm has been litigating, are the cuts associated with the two-midnight policy. The two-midnight policy has been around, came in 2013, and essentially raised the barrier to an inpatient claim from what had been a 24-hour stay or a 1 midnight stay to 2 midnights. That stays of less than 2 midnights are presumed to be outpatient, but there are all sorts of exceptions. And I don't want to dwell on this much because 2 midnights could easily justify its own webinar. But know that this is going to continue. There were some tweaks that were made in the 2016 outpatient PPS final rule. There have been some changes where now QIOs instead of MACs oversee these patient status reviews. But what we're here to focus on is the cuts that were made. And this is something that is just fundamentally kind of strange because CMS back in 2013 raised the bar or made it more difficult for a hospital to claim a case as an inpatient claim, but yet CMS calculated that there would now be more inpatient claims, even though there was a higher regulatory burden to claiming them. And so they decided that there needed to be an adjustment to total PPS payments, and that total adjustment was 0.2%. CMS recently, continued that 0.2% through fiscal year 2016, but 2014, when this started, is challenged in court, and there was just a notice issued yesterday in the Federal Register requesting comment until February 1st. There's an opportunity to comment on whether this cut is effective or not. So I commend to all of you that Federal Register notice from yesterday, and either directly yourselves or through your association, please go ahead and submit comments because we believe that this cut isn't warranted under the facts that were presented or are presented, and that this cut should be reversed by the courts, and that's still in play. But meanwhile, going back to kind of our larger topic here, we have the effect of a 2% cut. So what we have in this slide is a kind of a summary of everything to date. We see the market basket all the way on the right-hand column with 2.4. We have the ACA reduction. We have the productivity adjustment. We have the documentation and coding adjustment. It says 2 midnight continues. We didn't put that amount in there, but that's another 0.2%. So the total general adjustment, before even the sequester is taken into account, which is continuing, brings you down not just to the 0.9, but it's 0.7% of an increase. And then you take into account the 2% sequester, which is closer to 1.8 after the beneficiary copays are taken into account. So let me now hand it off to John to talk about DISH or whatever final comments he wants to make about market basket adjustments.
Thanks, Bob. I've got nothing further to say about market basket adjustments. Well, no, let me sort of. So Bob talked a little bit about the documentation and coding adjustment, which phases out in 2017, which meant that in 2018. 3.2%. There should have been a 3.2% increase to the market basket to take into account the expiration of that $11 billion cut. And we'll deal with it now because it is in a slide later, but we're talking about the market basket here. So in 2018, we should have seen a 3.2% increase to payments to account for the elimination of the ATRA adjustment, and now we're not going to see that. As part of the SGR fix, as part of MACRA, Congress decided to capture a portion of that 3.2% in savings to pay for the physician payment fix. And so instead of hospitals getting that 3.2% increase all in 2018, it's going to be pro rata rationed over the course of 6 years at 0.5% a year, and that prorating that over 6 years generates a significant savings. And that was my reference to the notion that when Congress sees these big bumps up, don't expect that it's actually going to happen. They see that as an opportunity for some budget savings, and so they implement that. But you know, let's talk about DISH now for a bit. Bob, next slide, please. So one of the bigger changes that were part of ACA was Section 3133, which really changed in a very fundamental way the way that disproportionate share hospital payments are made under the Medicare program. Traditionally, you know, you qualified for DISH based on your percentage of low-income patients to your total patient population. And if you qualified, you got a fairly significant adjustment, literally on the order of about $12 billion a year to hospitals in additional payments. And MedPAC back in 2008 sort of took a look at those DISH payments and said, you know, fundamentally, they're not really serving the purpose that they were intended to serve. The DISH system's not really that accurate in the way that it targets payments to hospitals. We think only about 25% of that is empirically justified in the way that it's handed out to facilities. And MedPAC made some recommendations about changing the system, and Congress picked up on that as part of ACA, and it saw an opportunity for some savings too. So what Congress did as part of Section 3133 was it split disproportionate share payments into, you know, what we'll call the empirical DISH payment and a uncompensated care DISH payment. The empirical DISH payment is 25% of whatever the Medicare program would traditionally pay out, and the uncompensated care DISH payment is the remaining 75% put into a pool and subject to a bunch of reductions. So let's talk about how that pool is handled by CMS, how it's calculated and meted out. Well, so the first aspect of this is you've got to calculate what the traditional DISH payment would have been prospectively to all hospitals in the country so that you can calculate what 75% of that is to put into a pool. And CMS does that calculation through the Office of the Actuary, and they look at various factors. They look at the growth in Medicaid, for example, as one aspect of that. And a little sort of assumption that CMS makes in that regard is how much Medicaid is going to expand, because Medicaid days are a big chunk of the equation. and how Medicaid patients are using hospital services, because it's really the measure of hospital service, how it impacts patient days, that factors into that calculation. And in the first year of this calculation, CMS assumed, and we think perhaps accurately, perhaps inaccurately, that the new Medicaid patients, so those patients that had become qualified for Medicaid as a result of the ACA expansion of Medicaid, would use services at about the same rate that other patients, traditional Medicaid patients, were using the service. And so no adjustment for that. But in the second and third years of this, the actuary, the Office of the Actuary, has essentially made an assumption that that new Medicaid patients, those that are in the expanded Medicaid population, will only use inpatient hospital services at about 50% of the rate of traditional Medicaid patients. And so it factored that into the calculation, and in the last couple of years, in the calculation of this 75% pool, we saw fairly significant reductions from that. And you'll see some of the numbers on this slide associated with the calculation of the pool. So once that pool is calculated, which is factor 1 in the calculation, we go to factor 2, and that takes the pool and it reduces the pool based on the increase in the insured population below the age of 65. And again, that's principally done by CBO, so that's based on CBO estimates, sort of locked in stone in that regard. That's not something that the Secretary does except for some annualization adjustments. And that takes into account the full Medicaid expansion, right? So even though those patients might not be accessing inpatient services at the same rate, and we think, by the way, that that's a dubious assumption. We've seen for the first time real data that supports the opposite of that, and we'll bring that to the agency's attention this year in the form of comments. But for purposes of this calculation, they assume that they don't care whether or not you're using inpatient hospital services. You've become insured. And the insurance rate has been, radically increasing over the last few years, such that for 2016, the pool was multiplied by a factor of 63.69%. So, we started with a pool of about $10 billion-ish, and we ended up with a amount subject to distribution to hospitals of only about $6.4 billion. If we were in the old system, that $3.6 billion would have been distributed in traditional dish payments. So there's a $3.6 billion savings to the program simply associated with the Factor 2 calculation. Just a heads up on this. So the calculation changes beginning in 2018 when the size of the insured population is measured a little differently. So beginning in 2018, the Secretary and not CBO will measure the increase in the insured population as compared to 2013. And it won't be based on a population that's under the age of 65. It's based on the full population, so it'll take into account Medicare for that purpose. We're still eager to see, and we will likely start seeing some inclination of how the Secretary is going to calculate that in this year's proposed rule. Bob, next slide. We just talked about this, so we can move on. And this is just a pro forma of where we think the calculation will go for 2017. That actually may turn out to be a little high. The estimate could come down into the 59% range. A friend of mine does this calculation. He's usually very good with these, and he won't let me say who he is. So I'm going to give him a thank you. I suspect he's in the audience. Next slide, Bob. Okay, we're now into Factor 3, and this is the controversial one. So you've got this pool of billions of dollars, and it's supposed to get distributed to dish-eligible hospitals. That's the first test. Are you dish-eligible or not? You may get the payment. It's meted out through the pricer on a per discharge basis but it's subject to reconciliation back to the calculation of the original number for each hospital. It's based on historical data. And this year it's going to be based on the same FY 2011 and 2012 cost report data. That is your Medicaid days and your Medicare patients with SSI days for a given DSH-eligible hospital as compared to all DSH-eligible hospitals in the aggregate. So it's a ratio of your data to everyone else's data, and that small fraction is then applied to the $6 billion plus pool, and that's your share of the pool. You'll get it throughout the course of the year, but it's ultimately reconciled back to the original calculation. Now, why are we using Medicare with SSI and Medicaid days? Why aren't we using a hospital's actual cost of uncompensated care? There is information that's available on that. It appears in a document that you file with your cost report called Worksheet S10. And I think I bear just a bit of responsibility for why we're not using Worksheet S10. When we got to the place before the promulgation of the first rule in FY 2014, I worked with a group that did some data analysis on Worksheet S10 and how hospitals were identifying their uncompensated care costs. This was a relatively new form at the time. The instructions, frankly, we did not think were particularly well written, but we did have some reported data for 2011, I think a little bit of data for 2012. And so we picked it apart and we found, lo and behold, given the quality of the form and the quality of the instructions, that hospitals weren't reporting their uncompensated care cost data consistently. And consistency is of primary importance with this calculation because remember, it's just a ratio. In the case of Worksheet S10, it would be your uncompensated care costs to the total uncompensated care costs of all hospitals. Making sure that each hospital reports that data in the same way is the only way to ensure that there's a fair distribution of those dollars. And we've cataloged in the slides later, and again, look at those offline if you want, all of the problems with Worksheet S10, but the bottom line essentially is if we'd used Worksheet S10, there was literally one hospital in the country that might have captured something on the order of 7% of all of the hospital payments in the system because it reported all by itself $1 billion in uncompensated care costs, which was actually 3 times, so 300% of the total charges at the hospital. And it wasn't the only problem like that out there. So lots of problems with Worksheet S10. We suggested to the Secretary that they needed to find a proxy for S10, which the statute allowed. And there's a RAND study and some supporting work by the Greater New York Hospital Association, which supported the notion that that was a reasonable proxy, but more importantly, proxy of data consistently reported by hospitals that had been available for quite a while, and that's the proxy. Now, here's the important thing to keep in mind. CMS is going to move to Worksheet S10 data for purposes of this calculation, and we're going to get in the proposed rule for 2017, so sometime around March or April of this year, we're going to get a timeline from CMS as to when they're working to move the industry to Worksheet S10 for this purpose. And we need to be vigilant about that. One, we need to be vigilant about clarification of the instruction and the form. And CMS, frankly, from my perspective, hasn't done enough work in that regard. More needs to be done before we move to use that data. And there has to be some provision before that data is used for some audits of the data to make sure that hospitals really are consistently and accurately reporting the information. So this year is a year for vigilance on the UC DSH calculation methodology, and I know we'll be paying a lot of attention to that. And I think, Bob, that's really all I have to say about DSH at this point. So let's move through that. A lot of slides. And again, I encourage you to take a look at them. And now we're going to go to Marty at this point.
Good morning or good afternoon, depending on your time zone. I'm going to try to flip through as quickly as I can here a set of final policies that build on the last few years around what we generally refer to as value-based payment, which is a growing phenomenon within the Medicare program, not just on the hospital inpatient and outpatient front. As you'll see there in the first slide, hospital value-based purchasing was authorized under the Affordable Care Act and applies to discharges beginning with FY13. I think there are several important points to make about the status of the program at this point. First of all, CMS calculates a value-based payment incentive percentage for each hospital based on their total score. It assigns a score, and then that score is applied to a pool of dollars which are made available by taking those out of the base operating DRG payments. So a pool of dollars is created each year. For 2016, we're now up to 1.75% of the dollars pulled back from the base DRG payments. The CMS then calculates the TPS for each hospital by looking both at the hospital's achievement as well as their improvement. And then those are in turn weighted across a set of domains. The measures that are used obviously have to be posted in advance because the performance period on which the payment is based has to be done in advance. Most of these metrics, if not all, as with the case with the hospital-acquired conditions and other payment programs, flow through NQF. The rule this year brought a number of comments, as it has in previous years, about the question of whether socio-demographic status is in any way affecting hospitals' ability to achieve certain scores or show improvement. And as has been the case in prior years, CMS fundamentally dismisses that. While it continues to say it will monitor it, its position is basically that the socio-demographic status is not a factor. Probably important for planning for the future is payments for 2018, in which CMS now has finalized 12 measures for the value-based payment program. It removed a couple of measures. In responding to comments that have come up around the AHRQ, Agency for Healthcare Research and Quality, PSI 90 measure, and these comments permeate the program, CMS again reiterates its support for them, while they note that there may be some issues around coding. It continues to say that it will continue to apply the PSI 90. There were also concerns expressed about whether or not there is a certain push-pull effect on the hospital value-based program with respect to the HCAPS portion of the VBP, particularly around pain management. And here the issue, and it's one which will bear watching, is whether or not the effort to reduce unnecessary use of pain medication is in turn affecting patients' HCAPS responses. CMS does not believe that's the case, but again, this is something that may be revisited. The other thing that I guess I would stress about hospital value-based at this point is for purposes of 2019, 20, and 21, no new measures have been proposed at this time, but CMS does comment in the rule and has under review whether or not, and if so, when, to incorporate measures around central line-associated bloodstream infection and catheter-associated UTIs. So while they did not add at this time, those two conditions are likely to be added at some point. We expect to see further action on that, if probably in next year's proposed rule, if that was the case. Moving on then to the issue of hospital readmissions reduction. Bob, can you flip forward to slide 34, if you wouldn't mind? Because this sort of tells the story. I apologize for doing this to you. Against all the comments and questions that are and in some cases quite justifiably raised about the hospital readmissions reduction program, this picture here really sort of tells the story. Readmissions are down. CMS views this, I think, justifiably as an indication that the program is working, and therefore comments made about concerns about the way the program is operating are always going to run up against this picture. Just to rewind a little bit then, as with the case with the hospital value-based program, the payments apply here to the base operating DRG. The readmissions program has obviously been under a certain amount of scrutiny. Notwithstanding that, if you look at slide 33, you'll see that in 2015, with the addition of some additional measures, we have seen some deterioration, which is to say more money captured back from hospitals. If you look at the far right column there, FY 2015, the average hospital penalty is up, the percent of hospitals penalized is up, and the percent of hospitals being affected with a maximum penalty is up. All three of these rather significantly. Whether or not that will prompt additional pressure to perhaps modify this program in the future remains to be seen. But I think, as you can see there, this last year, 2015, was not quite as effective or not quite as successful as the previous 2 years. A couple of notes about comments that CMS responded to or did not respond to in the final rule. One of the areas that CMS proposed for expansion was around acute respiratory failure. They did modify in the final rule the reach on that particular measure. Likewise, they also respond to concerns about whether or not these measures are having a disproportionate effect on teaching hospitals, and both in the case of the readmissions reduction program and the hospital acquired conditions program, basically CMS rejects the suggestion that this is disadvantaging teaching hospitals when they run their simulations. The next point that I think is probably worthwhile noting is MedPAC has raised some questions about whether or not the programs here are perhaps in need of some statutory correction, because as readmissions have come down, the total number that is still at risk has not been adjusted. CMS has basically said that's something Congress is going to have to fix. The statute's pretty clear. So to the extent that if you go back to that slide that showed progress in reducing readmissions, hospitals nationwide, if you will, across the sector, are not really getting credit for it because CMS believes that statutory requirements about the amount of dollars that are at stake cannot be changed. So that's something in the future Congress will have to address as this program continues to reduce readmissions. The final area that I want to cover is hospital-acquired conditions. And here, really, this is again an Affordable Care Act program. The HAC program, as it's known, is based on 8 measures that were adopted for 2015. The program was not materially changed for 2016. No big changes for 16. CMS did note that in responding to comments again about PSI 90, that in their view the measure remains valid and they will continue to use it. There is also in CMS's comments or response to comments from the proposed rule, CMS indicates that it will work with CDC on some of the infection measures that may be included in the future. For 2017, CMS notes that there will be a change in the ratio between domains 1 and 2 that will put more weight on domain 2 for hospital-acquired conditions. For 2018, again here CMS finalizes its proposal that it will try to address in 2018 central line infection and UTI infection. The suggestion that be delayed was dismissed by CMS. They intend to go forward with it in this program. And then I think the final point that one has to kind of take away from all of this is, for many years, much of the attention each year on the payment rule was what's the market basket update. And I think what we've seen over the past few years, and again this year, is that regardless of whether the market basket update is a good one or not, these reductions in these various value-based and performance metric proposals, hospital value-based, HAC, and readmissions, can fundamentally turn what would otherwise look like a good market basket increase to actually negative increases, depending on the hospital, depending on the particular sector within the hospital community. These 3 programs, as well as others, but these 3 in particular, are increasingly driving payment and loom as large, if not larger, in many respects than the market basket increase. And so, John, I think I pass it back to you at this point.
Thank you. Just a quick comment on readmissions reduction. One of the slides that Marty presented, I think it was slide 33, and Bob, please don't go back to that. Oh, Marty, you were still going to talk about GME and IME. Yes,
I'm
no?
sorry, yes. Yeah. There were not large changes in GME and IME. Again, I think the main issue there is if you have a rural track program, CMS does provide for, in this final rule, some transition, taking into account those circumstances where the rural hospital may move from rural to urban, and there are provisions there for transition, but hospitals will have to be sure to exercise their options on that.
Thanks, Marty. Hey, so just briefly back on readmissions reduction. So in 2015, the total size of the adjustment was $428 million. And we've always said that the way that CMS implemented the readmissions reduction factor was not what Congress intended, although it may adhere to the strict words of the statute. Our proof in that regard that CMS wasn't really implementing what Congress intended is based on the CBO estimate of what the adjustment was supposed to cost the industry. And so CBO estimated over the 10-year life of the program that it would save $1.5 billion over the 10-year budget window, which works out to $150 million a year. And as you would see from that slide, the adjustment in 2015 was almost 3 times that amount. And it has never been, I don't think, as low as $150 million, which suggests that there was some room for CMS, we think, take a broader view of what Congress intended and modify the adjustment a bit in specific ways that we have commented on over the course of the year. The problem is that darn graph. There's just, it's a successful graph, right? In that it immediately affected hospital behavior on readmission. Even before the adjustment was implemented, hospitals were changing their behavior. And so there's very little chance that CMS is going to tamper in any meaningful way with the adjustment. And I'll move on to outlier at this point. Let's get to that slide. Probably, I think, slide 39. Let Bob get there. There you go. So I've actually been working on the outlier adjustment that CMS implemented at the very beginning of PPS since about 1983, 1984. It's been an issue. And the issue is that CMS picks a target that has to be between 5 and 6% of total PPS payments, and it removes from total PPS payments that amount, and it's supposed to pay it out. I mean, that's sort of what the statute seems to call for. And there have been some years where CMS probably paid above its target amount, which has almost always been 5.1%. But overwhelmingly, and I mean truly overwhelmingly, CMS has tended not to pay out the full amount of the outlier reduction in hospital payments, and so it leaves sort of a shortfall in the industry's finances. And so we try to be as diligent as we can every year in our comments, analyzing how CMS sets the threshold. Because if it sets the outlier threshold too high, it won't pay out enough in outlier payments to hospitals such that the industry as a whole recaptures the amount that was deducted from their PPS payments. And I think, generally speaking, over the last few years, CMS has been on track. But honestly, I think CMS has been on track because every decade or so, or 6 or 7 years, we sue CMS when they get so far off track that it has a meaningful impact on payments, and we've had some success. We had the 84, 85 outlier threshold set aside in the early 90s, and in the middle 90s we challenged those thresholds again, and we were actually tossed out of court because the industry didn't submit sufficient comments on the problems with the threshold, and that's been fixed. We comment every year now. And we've sued CMS for the 2004 through 2006 threshold, and we've had a little bit of success. 2004 has been remanded back to the agency for further consideration, and we're going to just have to see how the Secretary responds to that. But we could end up back in court certainly for 2004, and depending on what they do with 2004, it could have an impact on 2005. But in response to that litigation, we think CMS has done a much better job of getting the threshold right, with the potential exception of the threshold that was actually used for 2015 at $24,758. We thought that was too high by several $1,000s, and unexplainedly so. So it went up by $3,000 from 2014, and in 2014 the agency did not overpay outliers. So we wondered where that $24,758 came from. CMS settled on a threshold for 2016 of $22,544, and that was from a proposed threshold of $24,485, and we took issue with the proposed threshold at that high a level, and CMS responded in the final rule, which we thought was really good and worthwhile. And we're openly engaged with CMS on outlier calculation methodology at this point. So I think those are good things, and I think this is, at least with this administration, heading in the right direction, where we actually get paid out the 5.1% that's being deducted from PPS payments. And I don't really have much to add to outlier beyond that. So next slide, please, Bob. These are the pay-fors associated with the sustainable growth rate fix, so the physician payment fix, that was implemented as a result of MACRA, the Medicare Access and CHIP Reauthorization Act. MACRA extended the low-volume hospital adjustment and the Medicare dependent hospital programs until October 1, 2017. And these were originally proposed by ACA, but expired. And they've been sort of continually extended, and this is the longest extension we've actually seen. So that's good news for those hospitals which are very dependent on Medicare payments. I mentioned this before. What should have been a 3.2% increase in the market basket beginning in 2018 is actually going to be phased in over 6 years at 0.5% a year. And then the probe and audit period for 2 midnights was extended by MACRA until September 31, 2015, and has now been administratively extended through December 31 of 2015. And we'll see where that goes. But I would not count on it running past the end of this year at this point. But those were some of the pay-fors associated with the first two. Especially the middle one was certainly a pay-for associated with SGR fix. And that's it for me, Bob. This goes back to, I think, Hope at this point.
Yes, thank you, John. We're going to now move for the next group of slides into a discussion of some of the highlights from this year's outpatient prospective payment system rule. As Bob alluded to in his discussion of the market basket update, we are seeing some movement with the 2-midnight rule in this outpatient PPS rule for 2016. So by way of just some brief background, under the 2-midnight rule, we essentially have a 2-midnight benchmark or presumption that hospital admissions are reasonable and necessary if the beneficiary's length of stay exceeds 2 midnights. Under this rule, CMS has suggested that and believes that stays of less than 2 midnights are generally not appropriate for inpatient admissions, absent some sort of rare or unusual circumstance or some other exception. The industry, the hospital industry and physicians have expressed some concern about the 2-midnight rule because it essentially it sort of removes the physician judgment from the decision about whether to admit a patient, especially historically if the physician knew that the patient may not need to be in the hospital across 2 midnights. So what we've seen is some positive movement in the 2016 rule with a change to the 2-midnight rule that essentially says that if an admitting physician expects a patient to need to be in the hospital for less than 2 midnights, that the inpatient admission nonetheless will be appropriate if it is based on the clinical judgment of the physician and if the medical record sufficiently supports that. So this effectively provides a revision or a supplementation to that rare and unusual circumstance exception to the 2 midnight rule based on physician judgment. Payment for Part A stays that are less than 2 midnights will be determined on a case-by-case basis, and looking at things like the severity of the patient's symptoms and the predictability of adverse outcomes and other factors that might suggest that an inpatient stay is appropriate, even if it's predictably going to be for less than 2 midnights. And one important change is that now quality improvement organization contractors will be responsible for conducting the medical reviews of these one-night stays. It may be that if the QIOs find that there are, a particular hospital has excessive or high volumes of one-night stays or stays that are less than 2 midnights, that the hospital might be referred over to the RACs, but at least that initial review will be conducted by the quality improvement organizations. CMS was pushed in comments to revisit the 2 midnight rule and consider a 1 midnight rule stay, and it suggested that if it were to make that kind of move, it may need to propose further adjustments to that 0.2% adjustment that Bob alluded to in his presentation. So it doesn't look like we're moving in that direction. Looking to the next 2 points on this slide, we saw in 2014 that CMS promulgated a new policy to package certain clinical lab diagnostic tests that were previously paid under the clinical lab fee schedule. And when those lab tests were performed on the same date of service as the primary outpatient service, under this lab packaging policy, those tests would now be paid under outpatient PPS and not separately paid under the clinical lab fee schedule. In the 2016 final outpatient PPS rule, we're seeing an expansion of that lab packaging proposal. So now lab tests will be conditionally packaged and not paid separately under the clinical lab fee schedule if they were provided during the same outpatient stay. So not just on the same date of service, but during that same outpatient episode. And they'll be packaged unless the lab test is the only service that's provided on a given date of service, or if the test is conducted on the same date as the outpatient service, but it's ordered by a different practitioner than the practitioner who ordered the outpatient PPS service, and the test was ordered for a different diagnosis. So there's some concern about how this is going to be implemented and how folks are going to figure out whether this exception applies, but we are seeing this expansion of the lab packaging. On the payment side, in 2014, CMS expected that, I'm sorry, Bob, this is back to the last couple points on the previous slide. On the payment side, CMS expected to see an increase in outpatient PPS spending and a reduction in clinical lab fee schedule spending as a result of this lab packaging. And to address it, it revised the outpatient PPS relative payment weights essentially to move money from the clinical lab fee schedule to outpatient PPS. After doing some retrospective review of 2014 claims, CMS has determined that it actually underestimated the amount of the spending that would continue to be made under the clinical lab fee schedule by approximately $1 billion. So essentially, CMS has determined that outpatient PPS rates were increased too much to account for these packaged lab tests. So to address that, in the final 2016 rule, CMS is implementing a 2% reduction in the outpatient PPS conversion factor. Despite extensive comments in the proposed rule about CMS's lack of authority and how, if anything, this adjustment, more data should be gathered before the adjustment is implemented, or maybe that it should be phased in over time, CMS in the final rule is moving forward with the full adjustment. Next slide, please. So just quickly, in the start of 2015, we saw the deployment of some new comprehensive APCs, and comprehensive APCs, or CAPCs, are payment classifications for the provision of both a primary service and all of the adjunctive services that are provided in support of that service. So at the start of 2015, we saw the establishment of 25 CAPCs. And also in 2015, CMS determined that there could be just a limited set of add-on codes that qualified for essentially a complexity adjustment when those add-ons were reported along with a primary CAPC. In the proposed rule, the 2016 proposed rule, CMS did not initially evaluate any additional add-on codes, but in response to commentary in the final rule, CMS has agreed with commentators and is now expanding the set of add-on codes that can be coupled with the complexity APC claims. And CMS also finalized 10 additional CAPCs that will be paid under that existing payment policy. Now we're going to move on to Bob, who's going to address some of the significant changes to cost reporting and the PRRB appeals process through this outpatient final rule in 2016.
Thank you, Hope. Yeah, I will spend a couple of minutes here and then hand it back to Hope to talk about the 2015 legislation. But briefly, counterintuitively, the outpatient PPS final rule includes significant changes to the Provider Reimbursement Review Board, or PRRB, appeals process that affects, for the most part, inpatient claims and cost report appeals. And although these changes were proposed in the 2015 inpatient PPS proposed rule, they weren't finalized in the 2016 IPPS proposal, but lo and behold, they showed up here. And for those of you who work in the area of cost reporting and in appeals, these are significant. They cover almost 30 Federal Register pages, and so this is something that, again, if you haven't focused on yet, you need to. They go into effect for fiscal years starting on or after 1/1/16. Most importantly is it now requires providers to include an appropriate claim for a specific item in its cost report, or to include the claim as a protested item properly described in accordance with CMS guidelines and quantified in order to receive payment for that specific item. And this applies without regard to whether the MAC is prohibited from paying the item or not, what we call self-disallowed claims, or historically properly self-disallowed, that didn't have to be presented to the MAC because the MAC couldn't change them anyway. And that rule about self-disallowance had arisen previously in the context of Provider Reimbursement Review Board jurisdiction. And what CMS has done is now made that inclusion of the previously properly self-disallowed claims as a condition of complete cost reporting. So those items, even if they historically had been properly not included in a cost report, now need to be included, even though they're not going to get paid, even though the MAC, will not pay them on it. Because what this rule says is that if that item isn't included as a protested item or somewhere else in the cost report, perhaps included as a request for payment with some kind of a notation that the hospital is aware that the MAC has rules that prohibit payment, then not only will that item not be paid as part of the cost report, there can be no reimbursement if there is an appeal of that cost report. So that's what the rules say. It's a significant change. Will it survive judicial scrutiny? Who knows? But that is the rule that will be going into effect for cost years on or after 1/1/16. Now, these, just to kind of, what we've done so far to this point is really focused on these regulatory and operational issues. This is where I'm just going to take 30 seconds to say the cost reporting process has historically been the province of kind of CFO and accounting types, and lawyers really didn't get involved until it came time to do the appeal letter. That changed a little bit in 2008 when the rules changed, requiring, as a condition of Provider Reimbursement Review Board jurisdiction, providers to include as protested items those items for which payment wouldn't be made or for which they needed to reserve because their MAC wouldn't make the payment, but again, we talked about properly disallowed claims as an exception. Going forward, the cost report submission process now has a significant legal component to it. If that cost report does not include certain items, either as a claimed item or as a protested item sufficiently and properly presented, then the hospital can get no payment. There is an exception, however, for Medicaid DISH claims, where where providers will be allowed to submit an updated list within a year after they submit the as filed. Now, there also will be an exception if the provider submits an amended cost report, or if the MAC reopens on an issue that had been excluded from the cost report, then the MAC has the discretion to allow that new item in the amended cost report or in a reopening. But as we all know, whether to grant a reopening request or to accept an amended cost report is purely within the discretion of the MAC. So the relationship between the MAC and the hospital is now more important than ever. Importantly, and this is the last point that I have on this, is one of the questions that came up in that final rule was now whether the CMS would more closely monitor MAC behavior to make sure there's consistency across different MACs and that providers are treated evenly within one MAC or among the different MACs. And CMS said there's no reason to develop any new standards concerning MAC discretion over requests for reopening or amended cost reports. And they said, we do not see a need to increase monitoring of contractor activity beyond the current monitoring that's performed as part of the annual contract reviews. That strikes me as short-sighted. I think vigilance is important. I think hospitals now have been warned that they need to be proactive. They need to work with their MACs. They need to establish those good relationships with their MACs, and they need to find a way that when they need to, either through the amended cost report process or reopening process, to have the MACs look favorably upon those on those requests. But providers and hospitals cannot rely on the MACs accepting these reopening or amended cost reports because it is purely within their discretion and not subject to judicial review. So with that, let me hand it back to you, Hope.
Thank you, Bob. On November 2nd of this year, the Bipartisan Budget Act of 2015 passed, and somewhat surprisingly to the hospital industry, there was Section 603 included in it, and what Section 603 did was target or hit off-campus hospital outpatient departments for site neutrality payment adjustments. So the way Section 603 works is that beginning January 1st, 2017, new hospital outpatient, new off-campus hospital outpatient departments and other non-exempt off-campus hospital outpatient departments will no longer be eligible for payment under the outpatient PPS payment system. It may be for those new and non-exempt outpatient hospital departments that are off-campus that some alternative payment system is available. So payment may be made under the physician fee schedule or the ASC or clinical lab fee schedule if those applicable payment requirements for those other payment systems are satisfied. So which hospital outpatient departments are exempt? As of right now, the new payment limitation does not apply to off-campus locations that are dedicated emergency departments. And it also would not apply to an existing off-campus hospital outpatient department that was billing Medicare under outpatient PPS before enactment of the Bipartisan Budget Act, so before November 2nd, 2015. So what are hospital outpatient departments that are off-campus? For purposes of, and you can move on, thank you, Bob. Off-campus departments are defined in accordance with the provider-based rule. So essentially, a hospital outpatient department will be considered off-campus if it is located more than 250 yards away from the main building of the main campus, unless CMS has determined that it should nonetheless be treated as on-campus. In addition, under Section 603, a hospital outpatient department is going to be considered on campus if it is located within 250 yards of a remote location. So if a hospital has two campuses, a main campus and a remote location, if the hospital outpatient department is located within 250 yards of the remote location, it will still be considered on campus for purposes of this payment limitation. So there are a number of problems with Section 603 as it is currently drafted. First, it's ambiguous because it doesn't address things like what does it mean to be billing as a hospital outpatient department under outpatient PPS before enactment. Does that mean, for example, that in order to get the benefit of this grandfathering, that the same entity needs to be doing the billing before November 2nd and after November 2nd? What happens, for example, if a hospital and its off-campus hospital outpatient departments undergo a change of ownership, such that before November 2nd, one entity was billing for those services. After November 2nd, the buyer or successor entity is billing for those services. Does that hospital outpatient department continue to get the benefit of the grandfathering? Section 603 also doesn't address unit relocations or expansions. So if there's an existing hospital outpatient department that's off campus, but it is going to be relocated to another location. Let's say that it's in a unsound physical location or another alternative site has been identified. If that unit or department relocates, does it still get to maintain its grandfathering? Same question about if the department expands. So if a current hospital outpatient department is located off campus, has been billing under the outpatient prospective payment system for some time, and expands the services that it renders after November 2nd, will those new services still be eligible for the grandfathering because the department itself was billing before November 2nd? So these are some of the ambiguities. A big concern about the legislation is that it doesn't include any grandfathering for hospital outpatient departments, off-campus hospital outpatient departments that were under development as of November 2nd. So, for example, if you are a hospital located in a certificate of need state and you have plans to build an off-campus hospital outpatient department and you have rented the space and you have gone through the CON approval process and you are undergoing construction, let's say construction is even complete or just about complete, but November 2nd has come and gone and you're not actually operating that outpatient off-campus hospital department yet, right now, Section 603 does not contemplate any way for the hospital to be paid under the outpatient prospective payment system for services rendered at that new location as of January 1st, 2017. So as a result of some of those ambiguities and the failure to include an underdevelopment sort of exception, there's been some discussion and some proposed amendments floating around to try and tighten up Section 603 and come up with some tighter definitions and exceptions. So some of the things that are being contemplated are carving out, for example, from the limitation off-campus hospital outpatient departments that are relocated or that have undergone a change of ownership. There's also some discussion, AHA has an amendment that's out there, there may be some others as well, to try and define or include an exception to the payment limitation for those hospital outpatient departments that were in fact under development as of November 2nd, 2015. In terms of how underdevelopment is defined, there's a bunch of discussion about that right now. So it could be defined really broadly, but my guess is that ultimately that if there's an underdevelopment exception that is built into the payment limitation, it will be pretty tight and will require things like, a signed contract for construction in effect before November 2nd, or maybe an approved CON in place before November 2nd, or some significant commitment of capital resources before November 2nd, so that CMS can be comfortable that the off-campus hospital outpatient department was truly under development. There's also an open question with all of this, even if successful, if an amendment is successful or some clarifying language, whether that will be done through giving the Secretary authority to promulgate regulations or to promulgate guidance to issue to approve certain exempted hospital outpatient departments, or whether this will be statutory in nature. It could be that as part of the appropriations bill that we're expecting in December of this year, that there will be some fix for Section 603. It could also be, if that window passes and the Section 603 fix does not attach to the appropriations bill, it could very well be that this trails out into 2016, either the first quarter or later, because the payment changes don't actually go into effect until January 1st, 2017. So there may not be the same sense of urgency to get this done in December. The challenge, of course, is that hospitals, for example, that had hospital outpatient departments that were truly under development before November 2nd, some have had to put those on hold because there's no assurance that they will get the benefit of an exception from this payment limitation prospectively.
All right. Well, that sounds good. Oh, thank you very much. I don't know, John or Marty, either of you want to comment on the likelihood that we're going to see any legislative change with respect to the 603 issue?
It's John. I just think we have to remember why Section 603 is there. So 603 was designed as a budget savings tool, actually not to pay for a healthcare change. This is one of the first times that we've seen cuts to healthcare payments that were designed to pay for something else. In this case, it was lifting the pay caps for military spending and discretionary spending. And so anything that we do to sort of clarify or fix 603 is going to be subject to scoring. And if the scoring of the exception is significant, then there's going to have to be a pay-for associated with it. And where's that going to come from? So I mean, I think it's unfortunate that the broader the exception, the less likely it's going to be that it'll see quick passage. And if it doesn't see quick passage this year, it's going to go into some hospital bill where some members of Congress are going to use providing an exception for this, as a reason to, cut Medicare bad debt spending or something like that. So that's unfortunate. I also think, and again, my own personal view, that the versions of amendments I've seen so far leave too much to CMS at this point that doesn't have a process in place to deal with this. So it could be many months. It could be before, it might not be until the OPPS proposed rule, which usually doesn't come out until August, that we would see something from CMS on this, and these projects can't wait this long. I think any fix here needs to be a statutory fix that isn't subject to, secretarial oversight, at least in terms of the projects under development, because we're getting calls every day right now with folks saying, hey, we've got this in the works. Is it going to be subject to this limit? Should we stop now? Is this just a relocation and we can feel comfortable that it's going to get paid? All of those things. And we're going to start approaching CMS on some of the things that we think fall outside 603. And we've got some protocols now for developing facts for those things. But it gets very complicated if this is left to agency discretion rather than Congress saying, look, if you've got a CON or you spent significant, some amount of money on this, or, you've got shovels in the ground, then we're grandfathering it. I mean, that seems to me to be the cleanest way to do this. Marty, how do you feel about it?
No, John, I think you covered it pretty well. If you look back over the last 10, 15 years, there are other examples where Congress adopted a measure similar to this to close off the development in a certain sector, and then return to it in relatively short period to provide some realistic transition for those providers or entities that were legitimately in transition. But both from a scoring standpoint, but also just from the standpoint of administrability, they need to be things which are relatively bright line. Ground has been broken, binding financial obligations, things that an entity, a provider, or others can present to CMS, and they can say, yes, objectively, you meet the mark. This is not something that is going to be probably considered if it's ideas jotted down on a napkin about let's build a new wing or something of that nature. It'll need to be fairly bright line examples that enable CMS to say yes, you're in, and yes, you're out. I think the other thing is there does need to be a little clearing of the air. 603 has stirred up a lot of dust and is raising a lot of questions about transactions that may have nothing to do with what 603 was about. And that's something, too, where I think CMS will probably need to provide, whether it's FAQs or some other kind of sub-regulatory guidance that makes it easier for folks to understand whether they have a problem or not.
Yeah, I agree.
Well, that sounds great. Jenny, I see we're almost to the end of our hour and a half, and I haven't opened it up for questions yet. So let me just turn it back over to you to see if there are any questions. But at this point, we'll just thank everybody for for listening in and give it and hand it to you, Jenny.
Okay, I just have a question for John, and that is, what should hospitals do to prepare for the changes to the S10?
Well, I'm not sure that there are going to be changes to the S10. I certainly hope that there are going to be changes to the S10, and we've outlined what some of those changes should be. I would just say at this point, pay really close attention to any town hall meetings that CMS may schedule between now and probably February, where they might preview some S10 related issues. And really pay very close attention to the proposed PPS rule that comes out, because we are going to see a schedule in there and we're going to see something on S10. There's just so much associated with how data is reported in S10 that's sort of subject to interpretation. It goes to the basics. What's an uninsured patient? A lot of government hospitals would say that their unrecovered costs of Medicaid patients should be paid, but those are insured patients. I mean, that's a form of insurance that certainly for ACA purposes is considered an insured patient for DISH. So, you know, should the unrecovered cost of Medicaid sort of fall out on that? What about, you know, county general relief patients where that care is paid for by tax dollars? Are those uninsured patients? You know, maybe, I don't know. But we got to have consistency with respect to those definitions. People need to understand who the patient population is for purposes of capturing uncompensated care costs, and they need to report that accurately. I mean, even what the definition of cost is for that purpose is ambiguous under the worksheet S10. People have treated that differently, at least based on our review of the S10 data.
Okay, thanks, John. Just have one more question here, and that is if someone could please explain what defines a hospital remote location.
Sure, hi, Jenny. This is Hope. I can take a stab at it. So a remote location is also defined in the provider-based rule, which is 42 CFR section 413.65. And a remote location is essentially a second or more location of a hospital where inpatient hospital services are provided under the same name and ownership and control of the main provider, and it's a location that is not separately subject to the conditions of participation. So what that means is it's an additional location that is a provider-based location that is owned, operated, and integrated with a main hospital location, and that's located off campus.
Okay, thank you very much, Hope. I appreciate that. I would just like to thank everyone for attending today, and hope that you received some excellent information, and we look forward to your participation in other webinars in the future. Thank you.
Thanks, everyone.